My name's Nick Agarwal. I just wanted to introduce myself. I'm one of the code course directors along with Suraj. Thank you to everyone for joining us on this beautiful warm Saturday. I'd like to introduce our next speaker, who's Dr. Drew Schembre, who is a gastroenterologist in Walnut Creek, where he serves as the director of the John Muir Digestive Health System. Today, he's going to be talking about POEM as a treatment option for achalasia. So thank you, Dr. Schembre, for speaking to us today.
Great, thanks, Dr. Agarwal. Can everybody hear me and see this? This is a little challenging to do this for those of us over 50, but I'll give it a whirl. So we're going to talk about POEM and some of the things that go with POEM. From the warm side of the bay over here, where it's actually very warm. So as I was preparing for this talk, I was looking through some previous talks and realized that the last in-person talk I gave was the night of the first White House COVID update. I remember that because I was driving down to Fresno and heard this on NPR and kind of wondered where the world was going. At that time, I pulled up this cartoon to try and add some levity to the talk at that point, and it seems kind of quaint in the old days when we were worried about your Purell. So as an update, we're still using Purell, but the world seems like a different place. So with no further ado, some disclosures, and we'll talk about POEM. As the great gastroenterologist Robert Frost once said, a poem begins as a lump in the throat and a sense of wrong. Turns out he really wasn't talking about POEM as much as he was talking about achalasia. And achalasia is this rare motility disorder, happens in about 1 in 100,000 people. It's characterized by loss of enteric neurons leading to the absence of peristalsis and impaired relaxation of the lower esophageal sphincter. We've all seen this. It's fairly uncommon, but now in the POEM days, these seem to be coming out of the woodwork. The cause is largely unknown, seems to be a result of a trigger, a viral or bacterial infection, leading to a cross-reactivity with either neurons in the ganglia or peripheral nerves, probably in genetically susceptible individuals. This leads to loss of motility and a loss of relaxation of the lower esophageal sphincter, leading to stasis of ingested food, regurgitation, chest pain, sometimes weight loss, and rarely late complications can be esophageal carcinoma and even aspiration. Again, there's some underlying insult, genetically susceptible individuals leading to an abnormal immune response and loss of nerve cells, then leading to achalasia. What we classically see, a big dilated esophagus with the bird's beak, poor relaxation of the lower esophageal sphincter, and stasis of all this fluid. And then if left untreated, you can get this end stage condition described as sigmoid esophagus, which does not even respond to the most aggressive sphincterotomies and usually will require an esophagectomy. 3 types of achalasia that are well described. Type 1 with loss of pressurization of the tubular esophagus and poor relaxation of the lower esophageal sphincter. Type 2 with this pan-esophageal pressurization and ineffective peristalsis, again with poor relaxation of the lower esophageal sphincter. And type 3 with high pressure synchronous spasm in the lower esophagus, again with poor relaxation, often causing more chest pain than dysphagia. And the treatments, there are several treatments, and these have been around for a long time. The cheapest and easiest, if not most widely used, is forcible balloon dilation. And the idea there is you put a very big balloon, 30 to 40 millimeters in diameter, across the EG junction, blow it up, and break those lower esophageal muscle fibers. It can be pretty effective and can treat this cheaply and easily. The big risk and the big worry, and the reason it's not performed more often, is this small but real risk of perforation, up to 7% in some series. And even though now we can probably repair a lot of that endoscopically, people have shied away from this. The other side effect with this, or limitation, I should say, is that dysphagia, achalasia, poor emptying tends to recur more often with forceful balloon dilation, probably because the myotomy is incomplete. You're relying on the balloon to break as many fibers as possible. But even with a few muscle fibers left, you can get scarring, you can get hypertrophy of those muscle fibers, and symptoms can recur. Probably the most common procedure is the Heller myotomy, and this has been around for over 100 years. First, obviously, as an open procedure, and then in the 90s, it has evolved to a laparoscopic procedure. One of the advantages to going in from the outside, doing a full thickness cut in the circular and the linear muscle, usually on the right side of the lower esophagus, just above the diaphragm, is that once you do this, you can do what's called a loose wrap, a door, or a toupee, to add a little bit of anti-reflux function to that now wide open EG junction. Very safe procedure, commonly done, low morbidity and mortality. But just like balloon dilation, we can see recurrence in a quarter or more of people at 5 years, probably more due to the natural history of slowly progressive dilation of the esophagus in achalasia than a limitation of the surgery. So what about POEM? The concept was not developed around achalasia, but really started as a spin-off from the notes revolution, really now almost 20 years ago. And the idea was that, if anybody remembers notes, can you get into the peritoneal cavity through the stomach, and how do you get it closed? And this was, again, before endoscopic sewing, before over-the-scope clips. And the thought was that if you could do a Z entry or tunnel through the gastric wall, you could offset the hole into the peritoneum through the serosa and the hole in the mucosa, and decrease leakage and close that mucosotomy more easily, and have a safer procedure. So Jay Pashrisha was doing this and thought, well, maybe you could do something at the lower esophageal sphincter, once you're in that tunnel. Inoue in Japan took that idea and really ran with it, and reported 43 cases in 2010 in humans, and really started the revolution of POEM. And 5 years ago, actually reported his first 5,000 cases, which is pretty phenomenal when you think about this idea having just started a few years before that. There have been over 10,000 cases reported in the literature by 2018. And many centers have picked this up. There is a learning curve. The first few cases can be really challenging, but it becomes more familiar after about 15 to 20 cases, and they describe efficiency, meaning you're not spending all afternoon doing this, by about 40 cases, and mastery, whatever that means, by about 60 cases. The technique itself is fairly straightforward. You go down into the esophagus, make a hole in the mucosa, tunnel along through the mucosa to the EG junction, get beyond into the proximal stomach, confirm your spot, turn laterally, cut the muscle, come out and close it. And what it looks like is something like this. And this is an older video, and some of these steps we've taken out, but basically we're looking at the EG junction. We try to extend the myotomy about a little below the high pressure zone, maybe 2 centimeters or maybe a little bit less now, and about 2 centimeters above it. And we want to make our mucosotomy about 5 centimeters above the extent of what we expect our myotomy to be. We often do endoflip beforehand, which gives us an objective view of what the pressure is and the distensibility is of that lower esophageal sphincter. This is a step we don't do much anymore, putting a little mark in the cardia with methylene blue. So we would theoretically recognize the cardia when we tunnel into it. That seems to be more of a waste of time, and we never really recognize that spot when we're tunneling. We do use the injector needle and methylene blue in the esophagus at our mucosotomy site, where we raise a bleb and then use a variety of tools, but we usually use a hybrid knife to get into that submucosal space, inject more dilute methylene blue into the submucosal space, and create a 1 centimeter mucosotomy that we can get the scope with a clear hood under the mucosa and kind of get into that gossamer-like submucosal space. And this is actually kind of the fun part of the procedure. It's if you ever, for those of you who grew up on the East Coast or in the Northeast, Midwest, when you walk to school in the morning in the winter, there was always ice on some of the little puddles. So you spend your next several minutes breaking the ice on the puddles with your cautery device using a little spray coag with your hybrid knife, injecting methylene blue underneath the space and cutting through some of that submucosal tissue. Occasionally, sometimes more often than not, you run into some large vessels. These hemostatic graspers are a great tool to get you out of trouble. And then you tunnel down until you're in the cardia. At that point, we put a separate scope, usually a pediatric gastroscope, into the stomach, and we can see this transillumination in the cardia that tells us that we've gone far enough. Then the work of the myotomy starts, and usually starting distally and working your way back, or once you're in, using the hook end of your hybrid knife, kind of catching into the circular muscle of the lower esophageal sphincter and using your endocut cautery to kind of cut through this band of circular muscle. In a perfect world, there's circular muscle and there's longitudinal muscle, and you stay out of the longitudinal muscle and just get the circular muscle. It's never that clear cut, and you end up often taking a moderate amount or even full thickness of the longitudinal muscle. It probably doesn't make much difference. The Europeans, as a rule, just cut through the whole thing and don't waste time with this careful cutting of the circular muscle. But for gastroenterologists who don't like to be in spaces that they're not familiar with, taking your time, carefully cutting that circular muscle, making sure that there's hemostasis in this channel is really important. And then once we're sure that we've got a good myotomy, we can come out, put our endo flip back down, and hopefully confirm that there's greater distensibility, greater diameter of the lower esophageal sphincter, and we've completed our mission. Now, the goal is to repair the damage you've done. And with a vertical incision in the mucosotomy in the esophagus, it's a lot easier to close this with clips, starting at the distal end, raising a little like a hill with the first clip, and then subsequent clips underneath it really can bring the mucosa together fairly quickly and effectively. You can also use a sewing machine to close that up as well, based on personal preference. So the post-operative care for these folks, we keep them overnight. NPO, pain medication, nausea medicine. They do often have some discomfort with this. It's not surprising after a big procedure like that. Most people go home the next day. We've rarely kept people for 2 days because of discomfort. We get a Gastrografin Swallow the next morning to make sure there's no leak, and then to reassure ourselves that there's good flow into the stomach and that the lower esophageal sphincter is open. We discharge them on full liquids for about a week, followed by soft diet for the second week, and then we see them in the office after that. We generally don't prescribe PPIs for these folks, but we do look several months later to see if they have any significant esophagitis. So the next morning, we may see something like this. Okay, Gastrografin Swallow. Most importantly, we're making sure that there's no leak at our mucosotomy site. And it's reassuring to see all this contrast going through the EG junction and settling out in the stomach without a residual column in the esophagus. And patients will often tell you at the time of the Gastrografin Swallow, because that's their first thing that they're taking PO. They're like, wow, that went down really easy. Success rates, again, very good in the 80 to 100% range. And like the other treatment modalities, we do see recurrence several years out that are similar. Complications, unfortunately, are not zero. They tend to decrease after you're more familiar with where you are and what you're doing, still range around 10%. Most of these are minor, things like pneumoperitoneum, rarely pneumothorax, rarely delayed bleeding. I used to think that these were really uncommon. I just had a patient come in the other day for a biliary problem, but she had had a poem done on the East Coast and described to me 2 weeks of hospitalization with 2 chest tubes and an open procedure. So clearly not without its complications. but it has been reported even in the very elderly and in children, and equally effective. So the big question, and this is, this comes up all the time, what's better, Coke or Pepsi, Poem or Heller? There are many studies and more recently 2 meta-analyses looking at this very question. Similar data, actually, they shared some of the same studies, the Annals of Surgery, looking at very large numbers of POEM and Heller myotomy, and found that there was what appeared to be slightly better improvement in dysphagia with POEM at 2 years, but more reflux, even though symptomatic GERD was similar in both groups. Almost exactly the same findings in the GIE meta-analysis from last year. Slightly better Eckhart scores at 2 years among POEM patients, but more reflux among POEM patients, but similar GERD. The interesting thing, it's like watching CNN News and Fox News. It depends on where you're coming from. The surgery group described in their conclusions, short-term results show that POEM is more effective in relieving dysphagia, but is associated with very high incidence of pathological reflux, whereas GIE suggested that long-term data were insufficient. Short-term efficacy of POEM is superior than that of Heller myotomy, and that esophagitis tended to be more common in the POEM group. However, the difference in reflux symptoms was similar between the 2 groups. So same data, different spin. What both agree on, and other studies have shown, is that in type 3 achalasia, POEM does seem to be better than Heller myotomy because you can make an easier extension of the myotomy. You can do a longer myotomy with less difficulty because you're already in the tunnel. Whereas with a Heller, you have to extend up through the chest further with much longer procedure times than with POEM. So what did POEM beget? POEM begot G-POEM, Z-POEM, all kinds of other acronyms, STIR or POET, poetry for esophageal strictures. I'm not going to go through all of these, but I think it is worth looking at a couple of them. G-POEM for gastroparesis. We see much more gastroparesis, frankly, than we do achalasia for a variety of reasons. And we do know that the therapies that we currently use are, I would say, minimally effective. And that surgical myotomy has been inconsistent, often because it requires a surgery that puts people on narcotic medication during recovery and often slows down any measurable effect of whether their gastroparesis has resolved. Stenting has been associated with high frequency of migration of stents, and Botox, again, short-term, and results have been inconsistent. The idea behind G-POEM is just like an E-POEM, except that you're doing it in a different place, injecting either on the greater curve or now more commonly on the lesser curve, raising a wheel, tunneling in, finding what they describe as the calamari ring of the pylorus, and then dividing that and then closing up the defect. Now, because I think one of the unwritten rules is that every talk has to have Stanford involved somewhere. I borrowed this video from Juha, a good friend of mine and other expatriate from Seattle, of a G-POEM procedure. I'm not going to go through all of it, but I will show some of the high points. Again, a tight pylorus at the beginning of the procedure, coming back along the greater curve, injecting a wheel under the submucosa with methylene blue, carving through that to get access. Here he's using a horizontal incision because he'll close it up with an overstitch rather than with clips. But again, once you get into that submucosal space, it's nice and blue. You can break the ice again with your cautery. It's lots of fun. Tunneling along until you see the calamari ring. He's beginning to see it down there at 6 o'clock. And here you have to be careful because the duodenal wall is very thin. You don't want to go too far beyond the pylorus. Once you identify it, you can start to divide it carefully, working distally to proximally. Like all of these, it's usually better to just go layer by layer rather than take too much. Take little bits at a time until you can recognize clear serosa at the bottom of those muscular rings. All right. Another perfect Juha procedure. Closing this up, looking at the pylorus nice and open, and sewing it all closed. How does it work? There are smaller numbers of studies with GPOM, but some really nice results, a variety of indications. Interestingly, these tend to skew more toward idiopathic gastroparesis rather than diabetic, and that might be why some of the outcomes are better. But in a lot of these, we see significant improvement in symptomatic scores, and also objective measurements seem to improve, with gastric emptying at 4 hours dropping significantly in most of these studies. Again, short follow-up, but in some meta-analyses looking at results, most have shown significant improvement in gastroparesis symptoms, but also objectively in improved gastric emptying. And that effect seems to persist at 1 month, 3 months, and even 6 months. Moving down the alphabet, ZPOM is the same idea in a different space. We've all seen big Zenker's diverticuli. The ENT people seem to take care of these pretty well, but why not employ POEM techniques to Zenker's? The same idea, tunneling under, exposing that frenulum or that muscle wall, and then dividing that and actually going below the diverticulum into the tubular esophagus to reduce recurrence. Again, a quick video, this stolen from GIE. We see the diverticulum, we come back, raise a bleb, tunnel under, speed that up a little bit. And then once you kind of find this wall of muscle, you can divide that fairly effectively. They use what's called a stag beetle knife, which is really more of a scissor, nice for this effect. Where is my, let me speed through this a bit. We're running low on time. And come on. Okay, there's the muscle. And we'll cut that up. And then you can see, you know, the muscle fibers clearly there, widely separated from both walls, and track down and then close that defect with clips. Again, the first clip is the most important because that lines everything up after that. And again, surprising how well these come together. Outcomes, smaller numbers, but this is a recent series of 75 patients who underwent ZPOEM for Zenker's, tended to be older, not the fittest people in the world. But the interesting thing is that the successes were pretty significant. Technical success, almost 100%, and clinical success over 90% in an older, tougher population. Average time was about an hour, which is significantly longer than the ENT folks who just put in a stapler and snip this and are done with it. So the comparisons between the rigid procedures and something like ZPOM are still, waiting to be done. Lastly, I'm not going to dwell on this, but you can do even more bizarre things like take out submucosal tumors in the esophagus and proximal stomach. The same technique. Once you're in the tunnel, you can do all kinds of things. Expose one of these stromal tumors, carve it all the way out, pull it out, and close that up. Most of those series are from China, Korea, Japan, but very large numbers. And they describe a variety of different outcomes. Most were able to get those lesions out. Complications varied from low numbers to moderately high numbers, and short-term follow-up. So in conclusion, POEM offers at least an equivalent alternative to Heller myotomy for patients with all types of achalasia with wide patient acceptance. It's still amazingly considered experimental by some insurers, and they sometimes won't pay for it. There are no CPT codes currently for POEM. But despite that, it has wide physician and patient acceptance with well over 10,000 cases performed and reported in this country. And this technique of submucosal tunneling and third space endoscopy does offer opportunities for expanding what we can do endoscopically. And it's a fascinating time to be in GI to see, where we're going with this. So, what seems like extreme stuff today may be standard tomorrow. Looking at an old album that I'm sure is in Neil Stolman's collection of vinyl, what were once vices, like putting holes in the esophagus, are now habits. If that seems like something of the moment, if we look back at these guys around the time that this album came up with a radical idea in colonoscopy and drew some things on napkins, and were told that if they did this, people would bleed to death, they would explode, there'd be perforations, when in fact they came up with snare polypectomy. So with that, I'll stop and take any questions.
Thank you, Dr. Schembre, for that great talk and those really cool videos as well. So we had one question from the group regarding the safety of POEM in cirrhotic patients, particularly well-compensated patients, obviously without varices, and whether that would be a safe procedure for them to undergo.
I would send those to Stanford. So we have had a couple of those, and if they don't have varices, it's probably safe to do, although I would carve out a lot more time and expect a lot more bleeding. The one patient with varices and cirrhosis that we were asked to do, we actually did a forceful balloon dilation instead, and he did fine. So would not be necessarily my first choice, but they're not going to get a Heller either. So in that situation, I would strongly consider a gentle forceful balloon dilation, because we're not so worried about the 5-year recurrence rate. We are worried about bleeding and getting into trouble.
And are there any other anatomical considerations like a hiatal hernia or paraesophageal hernia that you would think about before doing this?
Yeah, so every patient is his or her own challenge. Large esophageal diverticuli lend their own problem, but actually tend to resolve well if that myotomy goes up to the edge of the diverticulum. Hiatal hernia by itself doesn't seem to be a big problem. Most of those reduce when you put the scope in and you're pushing down into the cardia. A big paraesophageal diverticulum or a big sigmoid esophagus is a real challenge. And then you really have to ask the question, is this patient going to benefit from a myotomy, or is this esophagus just not going to drain even with a wide open EG junction?
And then, from an extraluminal approach for surgeons, they don't seem to mind, or at least some don't seem to mind about Botox, to give the patient some symptomatic relief. Whereas from an intraluminal approach, there's concern with fibrosis. What's your practice regarding Botox, particularly in the very symptomatic patients who might be waiting to be referred out?
Right. And this comes up frequently because somebody comes in symptomatic and we're going to be waiting for prior authorization and scheduling and all the rest. And many of them have already had Botox once or twice. And for one, it's a great pre-poem procedure to give them a sense of what they might feel like, and they get a little more enthusiastic about it. But we have seen a fair amount of fibrosis from people who've had Botox after Botox, and it does add significant challenge. So what I do, what our group does, if somebody's coming in, we will do Botox, but really just on the left side. So we'll do 100 units of Botox between 12 o'clock and 9 o'clock. And because it's a muscle ring, you really don't need 4-quadrant Botox. You just want to reduce the contraction or the resting tone of that muscle. And we found that if you just do that in the anterior left quadrant, as far away from your tunnel as possible, they get good symptomatic relief. It may not last as long, but that allows you to then schedule the procedure, give the patient some relief of their symptoms, and not mess up your dissection field.
Well, great. Well, thank you very much. And thank you for those amazing videos. And thanks again for spending your Saturday with us.
My pleasure.